Also, before we begin today's scientific session, I'd like to invite your attention towards a short corporate video which has audio visual representation about the Max Healthcare. This presentation actually highlights Max's journey over the years and their commitment towards the clinical excellence and patient-first philosophy and advanced medical infrastructure and the comprehensive range of the super specialty services that they provide all over the India. So kindly draw your attention towards the projector.
For over 25 years,
my dear colleagues, it is both a privilege and pleasure to welcome you all to this continuing medical education program on recent advances in oncology organized by the Max Patient Assistance Center and Rejoice and Relief Healthcare, followed by Arogya Rejoice and Relief Multi Super Specialized Clinic. I am Dr. Noli Hada, a cardiology enthusiast, a medical officer, and a program coordinator of Heart and Lung program at Chhatrapati Free Clinic Hospital. And I must say, I feel so privileged to be your master of ceremony for this event, which is being hosted here in this beautiful Vivanta Hotel in the heart of Chitwan, I guess. And so there's always a beautiful thought in medicine that we do not merely treat organs, but we care for human stories. Every patient who walks into the clinic arrives carrying far more than a diagnosis. Behind every biopsy report is a family waiting for hope. Behind every scan is someone quietly waiting and negotiating for uncertainty. And behind every scientific breakthrough lies the relentless curiosity of physicians who refuse to accept that this is as far as medicine can go. Medicine has never really truly belonged to any isolated specialties. the heart cannot ignore the lungs. Likewise, the lungs cannot ignore the immune system. And oncology has quietly taught us every discipline and profound lesson that healing is not only about defeating the disease, but also about preserving the dignity, compassion, and quality of life. As physicians, we have always been speaking about the survival curves, we are right, biomarkers, and then the treatment protocols, which never really ends. Yet, perhaps the most meaningful statistic is the smile that returns to a patient's face after hearing your treatment is working. This evening is a celebration of science, collaboration, and lifelong learning. More importantly, it is a reminder that every new idea discussed in this hall may eventually become someone's second chance of life. With that thought, let us begin this wonderful academic evening. As we all know that every meaningful scientific conversation deserves the thoughtful guidance, it is my privilege to invite our esteemed senior chairpersons to the stage. May I first request Dr. Dej Kumar Gautam, who is a senior consultant in surgical oncology and former executive director of BP Koirala Memorial Cancer Hospital. Sir, kindly have the honor. Likewise, I would like to warmly welcome Dr. Jaya Shrestha, who is a senior consultant in medical oncology and former head of Department of Medical Oncology at BP KMCH. Ma'am. Oh, she's on the way. So now I'd like to call upon our next chairperson. We have Dr. R.P. Baral, sir. Dr. R.P. Baral is actually the Chief Department of Oncology at Norvik International Hospital and Om Hospital and Research Center, Kathmandu, and is also a visiting professor at National Cancer Center. Sir, we're thrilled to have you. Also, I'd like to introduce you all to all the well-known dignitaries that we have in this room. So first, I'd like to introduce one of my favorite senior, Dr. Anil Bikram Karki, sir. He's actually the immediate past president of Nepal Medical Association and senior consultant oncologist, ENT at BPKMCH. Likewise, we have Dr. Guru Saran Shah, who is a consultant medical oncologist and head of department at BPKMCH. Likewise, we have Dr. Umesh Nepal, who is senior uro-oncosurgeon and head of department of uro-oncology and acting executive director of BPKMCH. Moving on, we have Professor Dr. Bikal Shrestha, who is a senior GI surgeon at COMS. Sir, we are honored to have you. Likewise, we have Dr. Keshav Bhurtel, sir, who is a senior gynae oncologist at Maula Kalika Hospital. So, we must say we're very thrilled to have you. We also have Dr. Sudeep Thapa, who is a medicine oncologist at CMCTH. So, hello once again, nice to meet you. So we have Dr. Hari Gaire sir, who is a pediatric oncologist at CMCTH. Likewise, we have Dr. Samir Sharma, who is a radio oncologist at BPKMCH. And moving on, we also have Dr. Lok Bahadur Sedai, Professor Dr. Lok Bahadur Sedai, who is a senior gyneco-oncologist and at Narayani Samudayak Hospital. So, now this is one of my favorite again because it is one of my favorite person from the cardiology world. We have Professor Dr. Mani Gautam sir, who is a senior consultant cardiologist. We're very thrilled to have you, sir. Kindly have the honor and be seated in the chair, which is located in my left hand side. So I'm going to call the names one by one. So I'd like to request the speakers to have the honor and be seated. First, we have Dr. P.K. Das, sir, who is the Vice Chairman and Medical Oncology of Max Smart Super Speciality Hospital, Saket, New Delhi, India. He's traveled all the way from India. Come on, he deserves a huge round of applause. Next, we have Dr. Raghuram K., who is a Senior Director and Surgical Oncology at Max Smart Super Speciality Hospital and at Saket, New Delhi, India. Likewise, we have Dr. Krishna Sagar Sharma, sir, who is a Senior Consultant Oncologist at BP Koirala Memorial Cancer Hospital. So please have the honor. Likewise, we have Dr. Jaya Shrestha. We already have him as a chairperson, who is a Senior Consultant Medical Oncology and past Head of Medical Oncology of BPKMCH. So we're very honored to have you. Cancer is perhaps one of the medicine's greatest teachers and one of the greatest challenges. It constantly reminds us that yesterday's impossible often becomes tomorrow's standard care. So to open tonight's scientific session, I'd like to request Dr. R.P. Baral, sir, to kindly come here and give the vote of thanks and open the session formally. Also, we have Dr. Keshav Burdel, sir, oncologist. So we're very thrilled to have you for the space to our respected.
Very first of all, huge congratulations and very thankful regards to the entire team of Max, because I know Max when it was born 25 years back. I was not aware of this program. My very dear good friend, whom I know since last more than 30 years, today is our eminent speaker, Dr. P.K. Das, called me yesterday night. I sleep at 8:39. He called me at around 9:30. Boss, hum Nepal aa rahe. So I was thrilled. So, God, where is the program? Bharatpur Chitwan. So I just called Bimlesh and Sabine Karki of Max. Then somehow I managed to come because I cannot say no to him and I cannot say to all my dearest and nearest oncologists and dear friends of Chitwan. We, the oncologists of Nepal, I'm proud to say that my other colleagues are here. We represent SARC Federation of Oncologists. When we came as oncologists, only few oncologists were there. Now we are proliferated like cancer cells, and now we are more than 150, I suppose, Guru, 150 members in our SARC Federation of Oncologists. So this is rapid proliferation of oncologists, not cancer cells. So in this period of time, in the last 30 years, I'm practicing more than 34 years, we have done many CMEs programs, symposium, international conferences, national conferences, to update and upgrade ourselves in the field of oncology. See, science is never ending. Science means always we gain something. Even we are seniors, we'll gain many things from today's CME. So in this meantime, from the era of single drug, I remember Dr. Samir, I remember Dr. P.K. Das, every lung cancer used to be given by cisplatin and etoposide, either small cell, non-small cell. Now every treatment is individualized. All breast cancers are treated differently. All lung cancers are differently treated. So this is the era of molecular science. Precision oncology is our main goal. So there are vast knowledge, and we proudly say that in Nepal, everybody are capable to treat all cancer patients. I should say or no, In my family, sorry to say, it's my personal issue. In my family, I have more than 74 cancer patients. My father died of cancer. My mother died of cancer. The kaka, kaki, everybody. But nobody went to India because I know the treatment doesn't change. So we should trust our oncologist. It doesn't mean we should not trust our Indian friends. So we are totally capable. And top of them, many centers are there in Nepal now. In Bharatpur, tertiary center, BPKMCS, leading cancer center of Nepal. In Kathmandu, many private centers and government centers are there. Even in eastern part, western part, there are lots of centers now. We are also proliferating and emerging. So पूर्वको मान्छे पश्चिम काठमाडौँ आउनु पर्दैन, काठमाडौँको पश्चिमको मान्छे काठमाडौँ आउनु पर्दैन, त्यही सेन्टर होस् भन्ने हाम्रो चाहना थियो, त्यो भएको छ. We are very proud of this all centers. So in this period of time, Max also has done many CMEs programs since last couple of years. Few months back, our Vice President Dr. Guru is there of SARC Federation, where he did a very important conference of SARC, and luckily, fortunately, Bimles has helped us from Max, and two eminent speakers were there. I do remember Dr. Deva and Dr. Nagendra Sharma. So likewise, today, he have invited two eminent oncologists from India and one our own eminent oncologist from Nepal as the key speaker. Before proceeding the program and before I invite the first speaker, today morning I went to Pashupatinath. I take round at 4:35 o'clock daily. Then I brought some very valuable Pashupati Rudraksha for these three speakers. So I would like to felicitate them by this Rudraksha Mala. In fellowship, don't put this and drink, okay? This is not religious. While drinking time in fellowship, please remove it. Dr. P.K. Das, you are invited. Samir, photo idhar. नहीं ऊपर फोटो अच्छा आएगा. Dr. Raghuram is a surgical oncologist. Will share now. Welcome. He has come first time to Nepal. He came today and is going tomorrow. It's very bad. One night stay in Nepal is not fair. Here आएंगे. Dr. Krishna Sagar, he has worked very hard to make this conference a great success. Thank you very much. Who are the famous medical oncologists in India? The first name is Dr. P.K. Das. You can try right now also. So that is his beauty. So Dr. P.K. Das, I have written myself something here. If I go and introduce you, it takes 1 hour, so I'll cut out my time. Dr. P.K. Das is very senior, most medical oncologist of India. Before here in Max, he was in Apollo Indraprastha Hospital, Sarita Bihar. Most of you have been there. He worked there for more than 26 years, from 2000 to 2026. He has done MBBS, MD, and DM from AIMS, which is a very prestigious institute of India. As I told, ex-senior consultant medical oncologist and clinical coordinator at Indraprastha Apollo Hospital, New Delhi since 2000 January to May 2026. Presently working as you know, Vice Chairman, a big post, Vice Chairman, Medical Oncology, Max Smart Super Speciality Hospital, Saket. There are lots of Max you saw. So he works in Saket, the biggest one. Is the best postgraduate AIMS product from New Delhi. Congratulations, Dr. Das. And he has done his fellowship in advanced treatment in hematology, malignancies, and bone marrow transplant at Peter Max Cancer Center, Melbourne, Australia. He's also a member of Advisory Committee on Oncology for new AIMS centers under Ministry of Health, Government of India. Expert committee member of Drug Controller General of India. Special interest, he has special interest in, as I said, newly targeted chemotherapy and immunotherapy in all types of cancers. And he has he has challenge of accepting treating rare challenges cancer cases. And he's also a member of ASCO, ISMO, lots of introductions are there. So today, to upgrade us in the field of oncology, he's going to talk about a very simple subject on trial
Rare and challenging cancer
rare
and
challenging cancer cases. We all treat cancers. Cancer is a big thing. So how to diagnose is a great challenge. How to treat is another great challenge. And the most important is outcome. So let's hear something new from Dr. P.K. Das. The floor is yours, Dr. Das.
friends, all our doctors, colleagues. So it's a basically honor to be here. On behalf of Max Hospital and all, I welcome you all. So, we are not talking very big science. As a team or as a doctor, you always, whenever the oncologists they come across, or as a doctor, you see different critical cases, complicated cases, heavily treated patients, refractory cancer patients. They come with a lot of hope. Can you do something? So this is our aim, to do something for rare or complex cases and all. So it's better to bring here. Okay. Okay. So the thanks to Dr. Baral, the way he projected me and all. So because I remember those days when I started my career from RNA Institute, joined Apollo Hospital. I was involved in your King's family for their treatment. I was one of the treating member in those days. So when you come to this Nepal, I feel it's a second home. So this is in coming to Nepal, just border to Bihar and all. So I feel as if we're talking to Indian friends, or where India and Nepal are same. So this is my this is my other colleagues who are with medical oncology, hemato-oncology, and the pediatric oncology work together. So in this hospital, so we know this cancer is a man-made disease. We all know. It's an aging process. Is going to have, everybody has a problem. You live long, you can get the different kind of cancers and all. We all know the way the things are going on. And this is the projected by 2050, this will skyrocket almost by in terms of 60% or so. So in terms of what is this era of precision oncology and all, if you see in oncology, you talk of chemotherapy, cytotoxic drugs and all. In the last 2 decades, there is no new chemotherapy has been developed. Last drug was eribulin. So no company or nobody is interested in the toxic drug. That's why these targeted drugs came, which target the particular enzymes or the precision-based molecules and all, and the immunotherapy and the drug conjugate. So to minimize the toxicity and all. So that's our aim actually. So we are not going to the details. I'll show some good cases, how you faced the problem to treat them, and in long run, how these patients are doing well. So we're not talking about what is this immunotherapy and all these things. This is a lady we treated in 2012. She was 30 years old, came to us from Kenya with just a feature of like sinusitis problem. So frequent sinusitis and all. So nobody was getting the diagnosis. He came to us and we ordered a polypectomy, and the diagnosis was T-NK cell sinonasal malignancy. It's a very aggressive, locally aggressive malignancy. So we know the limitation and all. So the patient came to us and we started with that is the time when this L-asparagine Pvt.Ltd was coming. And she was related to one of the bureaucrats, wife from Kenya. Somehow we managed. So if you generally we treated with an older regimen called SMILE regimen for this sinonasal malignancies and all. So this was the start at that time. That was the new. We started with Pvt.Ltd L-asparagine with the Gemux chemotherapy with 3 cycles, had a good response. After that, patient received radiation followed by 3 more. So after this therapy, she had a blackening. Like you feel as if this is the lady is having gangrene. That kind of features were there. Sorry. So see, because of this, we took the help of our head and neck surgeon. So we thought probably this is increasing. What all was necrosis because of the chemotherapy and the radiotherapy. So see, so this is the after the extent of the surgery. You will see, you did the debridement, and after the complete debridement, all this biopsy was negative, and we did a good reconstruction with a osteo-integrated silicon implant, and you see this defect. So it's very, very challenging. And you just imagine 30-year-old bureaucrat's wife want to do something. So, and yes, so with this implant and all, she is doing very well. And she is disease-free for the last 14 years. So sometimes this kind of difficult scenario and patients, they come. So this is one of the case we learned actually. So if you go by the science and follow the guidelines, you should get the benefit. But we are not always that happy or not very, very lucky. Not all patients, they behave in a similar manner. Many of the times we have seen, we follow the same protocol, treat in the same way, but the body or biology also sometimes different. This is another lady. This is very interesting. This lady, 39-year-old, with getting treatment for infertility for the many years for the child and baby. So she came with the first baby with the 16 week of pregnancy with a stage 2 CS cervix. What to do? And the bleeding was profuse. That was a challenge with the big growth. Because of the bulky cervix growth, she was having the bleeding. You can't give radiation. You can't do surgery. She was very adamant. She wanted the baby. She wanted the cure. She wanted the treatment. And you have to continue. Okay, the pregnancy also. That's very difficult. So surgery and radiation was not possible. So with this regular fetal monitoring, we offered 2 cycles of chemotherapy. And this chemotherapy, we know that in second trimester, few chemotherapies are safe after the organogenesis. So after this, so patient, the bleeding stopped. The cervical growth reduced significantly. And with this chemotherapy and all, every cycle before the chemotherapy, we used to do fetal monitoring for this baby. And the patients also would take care of all this neutropenia issues and all. We, unfortunately, this was the COVID time. And this time that lady had the COVID also. And somehow she recovered very soon. And we continued this chemotherapy till 37th weeks of the pregnancy. Because we can't do anything. Baby was doing well. So then after 37th week, cesarean was done and the baby was born. After the baby was born, then also cervix was very big, bulky. So we have to wait to time to get so that we can give the proper radiation and all. So 2 more cycles of chemotherapy followed by radiation, and till date, see, this is the baby girl. She's doing fine. See, so, and mother and daughter are disease free now. So similar, another case of, so we have seen why I'm talking about the infertility treatment. We are manipulating of the body with a lot of hormones and all. Some patients, they behave in a different way. This is another patient. And we have a very good series of patients with pregnancy and cancer. We have treated many different cancers, whether CML, Hodgkin's lymphoma, and this breast cancer. This is another patient. Similar story, getting infertility treatment, and at the age of 40, so she got a diagnosis of breast cancer and as well as this. But luckily, the breast cancer was locally confined, underwent the breast conservation surgery. After the breast conservation surgery, underwent chemotherapy, and this chemotherapy also similar way. We continued the chemotherapy till 37 weeks. Every time we used to monitor, fetal monitoring and all. After all, this baby has been delivered and they are healthy twin girls. She delivered this, and Then subsequently all this hormonal treatment and all is completed, and this is the few years back photograph. Just last month they came to see me. These are the grown-up girls now, both twins. You can see almost around they are 12 years old. So if you come across these kind of scenarios, we feel very happy to see this kind of your success stories and all. This is another patient, a very interesting, is a cardiologist from Bangladesh. So he was getting treatment for tuberculosis. So why tuberculosis? So the empirical treatment. Most of the time we used to tell our chest physician colleagues, whenever you start any empiric ATT, so don't continue the ATT more than 4 weeks. If you're not getting any benefit, please intervene after 2 weeks. So thinking of lung cancer and thinking of tuberculosis and delaying treatment for the investigation for the lung cancer is not allowed. So patient came and on investigation found stage 4 adenocarcinoma, but a very big disease. You can see everywhere in the scan. If you see the PET scan, everywhere the disease was there. So, and you see many of the time in our country or in Nepal also, you see very often this kind of picture, patient presenting in very advanced lung cancer and all. So with much difficulty, with oxygen support from Bangladesh, with air ambulance, this person came to us on ATT. So, and with this, we did all this molecular biopsy. After the biopsy, we sent this. EGFR was positive, and he's on osimertinib for the last 7 years. See the scan, he's absolutely fine. He's doing his job and watching everything, attending clinic and all, everything is doing. So another patient, this is a very famous software, and he is a startup. He is the owner of a startup company, computer software company. The young fellow, 36-year-old, get diagnosis of a stage 3B lung cancer in 2018. And at that time, the concurrent CTRT was a guideline. With the concurrent CTRT, he finished in December 2018. And just see, in the March, he had a progressive stage 4 disease with involving the brain and bone and all. This was the finding. And multiple brain mets and all. So we did the investigation. It came out ALK positive. So with this ALK positivity, there is so much, the way Dr. Baral was telling, we follow the principle these days. Don't hurriedly start chemotherapy for a lung cancer patient. If you're expecting some molecular alteration, please do a molecular test for the stage 4 days. It takes only 7 to 10 days maximum these days to get an answer. So these are the alteration. Accordingly, you can select the drug as per the mutation. So the patient received serotinib, then alectinib, and subsequently, because of the progression of the disease, we in the brain received radiation also, and see the disease in the brain. It is visible in the scan also, and because of the brain, he got the stereotactic radiation, and after that, we started with lorlatinib, and during this lorlatinib treatment, we learned a lesson in this patient. Patient had a new cavitary lesion in the lung. So this is the brain lesion. You can see after the radiation and all, this scan, and patient is asymptomatic. And here, so cavitary lesion in the lung was visible. We investigated and found that the patient is having tuberculosis. So we started with ATT. You have to be very careful, particularly the rifampicin. If you give rifampicin with this targeted drug lorlatinib, it can cause fatal hepatitis. So patient had within 2 days of rifampicin had a severe liver function derangement. So we stopped that drug. We followed it up, we researched, we saw that if you give lorlatinib drug, avoid this kind of drug. You have to be very careful about selecting the anti-seizure drugs.
Thank you for inviting me and providing this wonderful opportunity. So initially I talked about what topic should I present here. I discussed with Mr. Vimlesh. He said advances in oncology. Then whenever I think of advances in oncology, what with even patient as immunotherapy. In US, tablet cures the disease, and in Russia, a vaccine has been invented. Then I asked about who are the co-speakers. Then I come to know stalwart, senior veteran oncologist, Dr. P.K. Das is there. Then I thought better not to poke nose into the other field. Then I choose the surgical oncology field. There are advances in the surgical oncology too. And that has been proven. I came to here in Kathmandu. Then I was totally surprised. I was discussing with sir also. There are, every 15 minutes flight is there, connectivity. I never heard about that 15 minutes flight journey in between the cities. So I asked, why can't the road transport? Then I come to know that mountain hilly areas, it takes 5 to 6 hours. So obviously, necessity is the mother of invention. So technology helps here. Same is with surgery. It has to evolve and address the problems of the surgeons what we face. So I'll go to the topic proper. Can anybody know who is the veteran surgeon? Can anybody know how much is the mortality can happen to a patient if you operate? Chances are 100%. But have you ever heard about 300% mortality? Is it possible? How? Okay.
Certain operated on patient died, and among the assistant also got wounded. Assistant died.
Okay.
And visitor also died.
Spectator also died. Yes, he is a lightning surgeon. He used to operate in 20 seconds, 30 seconds only. Obviously it's before general anesthesia era. So he is Robert Liston. He used to operate very fast because anesthesia was not there. In his historic surgery, he was noted and got popularized because of this surgery. 300% mortality. He did an amputation, but he unfortunately cut the assistant hand also. Both died of gangrene. And the spectator watched. Spectator died because of shock on the bleeding. So it's a 300% mortality. So this is the whenever cancer patient diagnosed, there is obviously it's a major surgery. They are always thinking about the mortality and the morbidity. Even in day-to-day practice, patients used to ask, what is the mortality, what is the morbidity? But it has evolved over years, and right now, not only we are talking about mortality and morbidity, we are thinking about the quality of life undisturbed, going to the patient, going to the day-to-day activity very fast. So and not only the technology has improved and the quality of life has been improved for the cancer surgeries. Now it's the era of de-escalation also. Initially, what the cancer surgeon thinks is what we must remove. What are the organs we should remove? Now the era is gone. Now what are the structures we can preserve, providing the good oncological outcome also. This is the Halstead era. You can see the in the picture on the left side. Pectoralis major also removed. Then modified radical mastectomy. Now breast conservation surgery. Breast is totally preserved. Here you can see on the right side is a robotic assisted mastectomy, where we can preserve the entire breast flap and after putting the implant, and this is the contour of the breast. So the quality also preserved. That is the evolved. The technology has evolved so much. So what's the history and evolution of oncological surgeries? So cancer surgery, removal of the organ, high morbidity and mortality, high blood loss, less technological aid, prolonged hospital stay, no or less return to the come back to the normal life, and the fear of undergoing surgery because the tools were limited that time. Now the tools are very much for the surgeons. In fact, we are confused to choose which tool to prevent the morbidity of the surgery. So the era is gone. Less is more right now. Less treatment, less surgical removal with the same quality oncological outcomes. That is the era going on now. That is organ preserving approach. Transition from radical mutilating end block resection to function preserving. Role of effective neoadjuvant systemic therapy is shrinking the surgical boundaries. So whichever organ you take, breast conservation surgery, sarcoma, limb salvage surgery, kidney, nephron sparing surgery. And if you think about lymph node, radical lymphadenectomy to sentinel lymph node dissection and sampling, and margins helps us in removing less. Whenever in doubt, frozen section, and no need of compartment resection, radical resection nowadays. That is the one development, that is organ preservation approach, less removal, providing the good quality. That is one advancement happened in the surgery. Second is the expansion in the surgical spectrum. Once, if you know peritoneal disease, CA ovary or appendicular carcinoma, colonic carcinoma with the peritoneal metastasis, goes straight away to the palliative care. No cure, only palliative care and best supportive care. That spectrum has been increased. There is a selective subset of the patient where the biology is good. That is especially in the peritoneal surface, and the terminology has come. In 2011 only, this peritoneal surface malignancy terminology has been coined because it is not a systemic disease. It has spread through a different pattern, transcelomic spread, translymphatic spread. You should think it as a loco-regional disease rather than the systemic disease. So in that case, cytoreductive surgery and HIPEC plays the role. And one more thing is concept of oligometastasis. So it started with one meds, single meds, solid organ malignancy with single meds, still curative thing. Then two meds, now it has come to three meds. So three meds, it's still curable in a selective subset of patients, obviously not all with the good biology of the good biological tumors. So it is not based on the anatomical location where the tumor has gone. It is depend on multiple factors, that is patient parameters. The patient is a young patient with a good life expectancy left behind, and the tumor parameters, good biology, well differentiated, and the most important thing is the disease-free interval or the progression-free interval. With the patient, even though metastatic disease with the oligomeds, if the patient is progression-free for a year, minimum of a year, that patient has a good biology, and we should attack it with this advanced surgical treatment like cytoreductive surgery and HIPEC. So the expansion of the surgical spectrum has increased. That is one advancement happened in the recent era. And another thing is the disease spectrum for HIPEC. These are the spectrum. So top four occupies, we do routinely ovarian cancer with peritoneal disease, appendicular tumors with peritoneal disease, and colorectal and pseudomyxoma peritoneal is a strong evidence. Even though peritoneal disease, it is still totally curable. What is HIPEC? Just a quick word, that is, it's a high temperature. It is a type of chemotherapy with hypertherm pump used for the administration of chemotherapy, mixed into the fluid, into the abdominal cavity, and maintain it to 41 to 43 degrees Celsius over 60 to 90 minutes. The concept is hyperthermia kills the disease. And one more thing, whenever you remove this type of spread is because peritoneal disease has less vascularity, systemic drugs cannot penetrate that. There is a peritoneal barrier. So if you remove the disease and before the scar formation, if you give this hyperthermic chemotherapy, that is a solid role in preventing the relapse and providing the overall survival. I'm not going much in detail into the rationale for giving HIPEC because it's a pharmacokinetic advantages of IP therapy, tissue penetration, heat itself kills the cells. So treat peritoneum as an organ rather than it is a metastatic site. It has own histologic structures, own circulation and drainages, and like other organs, it needs an own and particular treatment, that is cytoreductive surgery and HIPEC. That is the reason advancements happen. So biology is the king. So think about the biology. Advances is the video is there. So. And another advances is the proper surgical advances, that is the technological advances, which has so much of technological advances has happening. Operative outcome, same surgery but better method, but maintaining good oncological outcome. Number of surgeons adapting this robotic surgery. Robotic surgery is there in the field since 2010 technique because of the obvious advances in the perioperative care. Perioperative care is excellent. The patient walks on day 2, tissue handling, and less cuts, less pain, less hemorrhages. This is one thing, all surgeon availability of the robot and the training part. Tumor, this is a old technique where we can see here with the bone cement with mesh reconstruction, but it's still the workhorse for the chest wall reconstruction.
pursuit to understand, to heal, and to restore and hope. And this pursuit is beautifully reflected in oncology. What was once considered an inevitable battle against the uncertainty has transformed into an era of precision, personalization, and possibilities. Every advancement reminds us that behind every diagnosis lies not merely a disease, but a person with dreams, relationships, and a story waiting to continue. As we gather on this meaningful occasion of Shravan Pandra, while we celebrate the sweetness of tradition, we also celebrate the sweetness of knowledge. As in Nepal, so today is Shravan Pandra, we celebrate it as a Kheer Khane Din. Okay, so we also celebrate Ashar Pandra. Ashar Pandra is the day when we eat, आप लोग बोलते हो ना पोहा, ठीक है, पर वो पोहा के साथ, हाँ, चूड़ा के साथ हम दही खाते हैं उस 15 वाले पे, एक मिनट। अब अभी ना हम खीर खाएंगे, उस टाइम पे अगर आते तो आपको शायद वो मिल जाता, but yeah. Anyways, coming back to the thing, because knowledge becomes more valuable when it is shared and therefore multiplied. To continue this journey of learning and innovation, we are honored to welcome two distinguished pioneers who have dedicated their lives in redefining cancer care in Nepal. First, we have with us a true master of surgical oncology whose journey represents precision, leadership, and whatnot, an unwavering commitment to healing. Professor Dr. Bhaktaman Shrestha, senior oncosurgeon at NPI, NSH, and past chairman and executive director of BP KMCH. Let's give him an honor with a huge round of applause. Through his remarkable contributions to the surgical oncology and institutional development, he has inspired generations of clinicians and strengthened the foundation of cancer care in the nation. Joining us another eminent personality in the field of radiation oncology, a visionary who represents the evolution of modern cancer therapy through scientific rigor and innovation, Dr. Ranjan Bhatta Bhandari sir, who is a radiation oncologist and immediate past head of department at radiation oncology at BPKMC. So we are really thrilled to have you, sir. His dedication towards advancing radiation oncology and embracing evidence-based, patient-centered approaches continue to shape the future of cancer treatment. So your journeys have reminded us that medicine advances, and not only because of technology, but also because of the individuals who dare to imagine, innovate, and serve. So now I'm handing over to respected Dr. Jai sir.
Next speaker, I want to so I want to
Thank you, Chairperson. Thank you, Chairperson. Jadiba. Okay. Thank you, Chairperson. Dr. R.P. Baral, all the way from Kathmandu to be with us this beautiful evening. Dr. Dej Kumar Gautam, immediate Executive Director of the BPKMCH and immediate Head of the Department of Medical Oncology, Dr. Jaya Shrestha, is the Chair of the 3 dignitaries. And all the senior dignitaries in the field, so from Dr. Bhaktaman Shrestha up to all my seniors, my co-workers and my कार्यक्रम Rejoice and Relief Private Health Limited को इनिसिएसनबाट सुरु भएको थियो र उहाँ 25 वर्षदेखि नेपालका प्रधानमन्त्री मन्त्री लगायत विभिन्न मान्छेलाई इन्डियाको दिल्लीमा भएको हस्पिटलमा 25 वर्षसम्म लामो सेवा गरेर हजारौं 100% डिस्काउन्टदेखि लिएर मेरो डिस्काउन्ट गरेर नेपाली कमिटीलाई 25 वर्षदेखि दिल्लीमा उहाँले सहयोग गरिराख्नु भएको थियो र अहिले उहाँ नेपालमा आउनुहुन्छ र उहाँको एउटा यो रिलिफ एन्ड रिलाइफ कम्पनी प्राइभेट लिमिटेड जसले टुरिज्म नेपाल भारत मैत्री बस लगायत यो मेडिकल टुरिज्म त्यसमा पनि विशेष गरेर नेपाललाई इन्डिया जाँदाखेरि छुट गर्नुपर्छ भन्ने एउटा अभियानको अभियन्ता हुनुहुन्छ त्यसले गर्दा उहाँका सबै हस्पिटलमा हुन्छ यसको पछाडीको उहाँ हुनुहुन्छ र त्यसपछि उहाँको सबैतर्फबाट म केही समय डाक्टर भक्तमान श्रेष्ठको एउटा ले मलाई इन्ट्री गरेर म 25 वर्ष क्यान्सरमा गर्दै गर्दा केही न केही आफू अब रिटायर लाइफतिर जाँदा केही गर्नुपर्छ भन्ने हिसाबले उहाँसँग मेरो आरोग्य आरएनआर मल्टिस्पेसियालिटी क्लिनिक भर्खरै अघिल्लो हप्ता नेपाल सरकार स्वीकृत गरेर अगाडि बढाएको छु र यसले मैले विशेष गरेर पिडियाट्रिक क्यान्सरको हिसाबले अगाडि बढाएको छ भने भविष्यमा यसलाई हामीले अरू फिल्डमा लिएर जानेछौँ, यसको यहाँनिर छ। र तेस्रो कुरा अहिले हामीसँग 20वटा भन्दा मल्टी स्पेसालिटी हस्पिटलसँग एमओयू भइसकेको छ दिल्लीमा, र त्यहाँ जाने आरोग्य क्लिनिक थ्रु जानेलाई 15 देखि 25 वर्षसम्म छुटको व्यवस्था विभिन्न ठाउँ भएको छ। त्यसमध्ये म्याक्स स्पेसालिटी पनि एउटा हस्पिटल हो र विशेष गरेर विमलेशजीलाई म धन्यवाद दिन चाहन्छु। उहाँले हामीले यो गरौँ न, यो आरोग्य र आरएनआरबाट केही गरौँ भन्दा उहाँले एउटा सहज उसामा हाम्रो एक्सपर्टहरूलाई लिएर आउनुभयो र नट ओन्ली वान सर्जरी, मेडिकल अङ्कोलोजी र पिडियाट्रिक तिनटै फिल्डमा राखेर कम्तीमा पनि हामी सबै मेरा विशेष गरेर सिनियरहरू, मेरा कोवर्कर्स, जुनियर्स, स्टुडेन्ट सबैको बिचमा यो राख्न पाउँदा मलाई अभाग्य लागेको छ। र मैले यति भन्दै अब दुईजना यस्ता इमिनेन्ट स्पिकरहरू इन्टरनेसनल डाक्टर पीके दास र रघुरामजी पछि मैले भन्नु खासै धेरै कुरा केही छैन, तर आई जस्ट ट्राई टु जोइन द पिडियाट्रिक्स एक्सपेक्ट र यसमा पनि रेसेन्ट एडभान्स वाट वी आर डुइङ। र विशेष गरेर मैले डाक्टर भक्तमानलाई एकचोटि उठिदिन पनि अनुरोध गर्दछु र उहाँलाई म सम्मान पनि गर्न चाहन्छु, किनभने हुनुहुन्थ्यो। म 25 वर्ष पहिला क्यान्सरमा जोइन गर्ने बेलामा अथवा मेडिकल अफिसर डाक्टर अनिल हुनुहुन्छ, उहाँ कोवर्कर्स, बच्चाको क्यान्सर उपचार नै हुने थिएन। जुन बेलामा बच्चाका चाहिँ धेरै निकै हुन्थ्यो, त्यो बेलामा म क्यान्सर हस्पिटलमा उहाँले सर इन्ट्री गराउनुभयो र फर्स्ट टाइम पिडियाट्रिक डिपार्टमेन्ट सुरु गर्यो। लक्किली उहाँले मलाई फेलोसिप गर्न पठाउनु भयो जापानमा र आई विल बी द फर्स्ट सर्टिफाइड पिडियाट्रिक अङ्कोलोजी अफ द कन्ट्री। आई एम ए पिडियाट्रिक अङ्कोलोजिस्ट हियरको लिड गरेको छु। थ्याङ्क यू डक्टर भक्तमान, बिकज हियर इन 25 years I have seen more than 6,000 children. I think more than 40% they have survived around our country. So this credit go to all the visionary leaders who are dynamic leading the hospitals in the past. Or maybe I am now toward the end of life. So I just want to say few things in about leukemia, so that this is the commonest cancer in the pediatrics. र यो ग्लोबल्ली हेर्ने हो भने करिब करिब 4 बिलियन पिडियाट्रिक क्यान्सरहरू छ 0 to 19 इयर्ससम्म, र यसको 2003 मा हेर्ने हो भने 377,000 इज डायग्नोज एन्ड 144 डेथ इन पिडियाट्रिक क्यान्सर। र यसमा अझै भन्ने हो भने ल्युकेमिया इज वान अफ द कमनेस्ट क्यान्सर, अराउन्ड 35 to 40% छ। वेयर 25 वर्ष अगाडि कुनै पनि बच्चा क्यान्सर बाँच्दैन थियो भने नाउ वी आर से मोर देन 90% pediatric cancer are died in the world, even in the Nepal they are dying with the chemotherapy in our low resource setting as well. That is the beauty of the pediatric oncology. And but more than 90% children in the developing countries dying with the cancer, whereas in developed country more than 80% they are surviving. So that's the disparity between developed countries and underdeveloped countries. And the main problem what we have, maybe diagnosis is delayed, major barriers might be diagnosis delay. Why we are not curing people less like the developed country? Delay diagnosis, and even we had a limited essential medicines, inadequate pathology, molecular diagnostics, workforce shortage, and treatment abandonment. These are the common, otherwise we could survive maybe many children in the Nepal as well. But delay diagnosis, still we do have referral. So we do have so many sessions in community, in college. Yesterday only, मैले हाम्रो हिजो सर हुनुहुन्थ्यो, हाम्रो देवचुली कलेजको प्रिन्सिपल हुनुहुन्छ सर, अध्यक्ष, उहाँलाई उठिदिएको छ। हिजो बेलुका मात्रै उहाँले मार्क्स हेल्थबाट त्यहाँको कन्सल्टेन्ट मलाई जोडेर 3500 भन्दा बच्चा बढी कलेजका स्टुडेन्टको बिचमा, प्यारेन्टको बिचमा चाहिँ चाइल्डहुड क्यान्सर र सर्भाइकल क्यान्सर अवेरनेस गर्नुभयो। त्यो खालको कम्युनिटी हामी विभिन्न गरिरहेका छौँ। धन्यवाद सर फर दिस कोअर्डिनेसन। लिमिटेड एसेन्सियल मेडिसिन्स, तर हामीसँग मैले 2012 देखि सेन्जुसको फेलो भएदेखि चाहिँ नेपालमा बच्चा क्यान्सरलाई फ्री गर्नुपर्छ भन्ने कुरा गरेको थिएँ। डाक्टर भक्तमान इट्सेल व्हेन यु एज अ डाइरेक्टर हि मेक फ्री लेस देन 50 years सिन्स देन। गभर्मेन्टले बल्ल एक दिन अगाडि बढेको थियो भने सेन्जुसको सपोर्टबाट 200 मिलियनको प्रोजेक्टबाट 35 एसेन्सियल मेडिसिन्स अहिले बिपी क्यान्सर मात्र होइन, नेपालका सबै हस्पिटलबाट फ्रीमा भएको छ। डाक्टर उमेश नेपाल यहाँ हुनुहुन्छ, उहाँले धेरै कुरालाई आएर सहयोग गर्नुभएको छ। वी आर द फ्यामिली सपोर्ट अफिसर, वी हेभ द इन गभर्मेन्ट हस्पिटल फ्री एभ्रिथिङ्स एन्ड इभन monetary support for diagnostic thing we are doing, and not less than some other country which the country मा नभएका चिजहरू पेट सिटी स्क्यान, मोलिकुलर डायग्नोस्टिक, जेनेटिकको लागि हामी इन्डियाका विभिन्न ठाउँमा हामी कोअपरेट गरिरहेछौँ र इभन कस्ट इफेक्टिभ रूपमा इभन नेपालमा भर्खरै सुरु भएको कार्डी सेल इभन बोन म्यारो ट्रान्सप्लान्टलाई भन्दा पनि कहिलेकाहीँ हामी दिल्लीसँग एक्सपर्टिजहरू सेयर गरेर बच्चाहरूको क्यान्सर अथवा नट ओन्ली बच्चा ठुलो मान्छेहरूको उपचार गरिरहेका छौँ। त्यसले गर्दा वर्कफोर्स सर्टेज थियो। I was in the first oncology in the Japan. Now I have already running 5th batch of fellowship in BP Korea cancer, more than including pediatric, more than 12 subjects. So that we have already advancement and treatment abandoned ko lagi. Pediatric, especially pediatric department, my BP Korea cancer, we have the family support officer, we have the monitoring support, we do have the social worker, dedicated to pediatric, we do have the dietitian separately for pediatric, we do have the data manager. So thank you, Dr. Umesh, as a executive director. So he make other things from last 2 years. So maybe in future we can cure most of the pediatric in our own setting in our own country. But there is always advancement in the country. So many advances we have seen from the last 2 speakers. So we are outsourcing, we are taking help, and Arogya Clinic also taking the free teleconsultation to all the hospitals expert in the Delhi. So including Max, Apollo, Medanta, even so many hospitals we have EMU, the free consultations without reaching the Delhi, we can get advance from them and we can treat over here also. There are so many patients are getting benefit. Thank you all the team from Max and other hospitals for this setting. So that's how we have workforce shortage and treatment abandonment was reduced. We try to work on this area. WHO Global Initiative Childhood Cancer को लागि अहिले यो हामी 60% भन्दा बढी 2030 सम्म नेपाल लगायत बताउने भनेका छौं। अहिले हामी अराउन्ड 40% को वरिपरि छौं। स्ट्रेन्थन हेल्थ सिस्टम, अर्ली डायग्नोसिस, स्ट्यान्डर्ड ट्रिटमेन्ट प्रोटोकल, र we already made few national guideline for the pediatric case, just like retinoblastoma we have finished, non-Hodgkin's we have finished, Willis Trigger we have finished, we are in the Hodgkin's disease. So many national protocol we are all building in national side, and universal access to medicines, comprehensive supportive and palliative care. First time Nepal we have made the pediatric palliative care for training development for health workforce last year under my leadership as a global leaders, and that's what awarded to around $70,000 to extend to Nepal, Bhutan and Pakistan last year by the WHO. Then we are taking that to not only country, we are helping the others in Bhutan and Bangladesh and Maldives also with that pediatric palliative care national training manuals for the country. So that's why we are working in from last many years. National Childhood Cancer Registry also established. So we are taking the registry with all the 4 major hospitals, just like BP Korea Memorial Cancer Cell, Kanti, Patan, and Vachu. We have a dedicated pediatric cancer registry. So we maybe within few years we could have the some show just like these are the number of patients, they have lots of amendment. This is a cure that we can produce country-wise, and BP Korea Cancer Cell leading the cancer registry. That will also give us lots of perfect pediatrics. And like that, so we do have so many things in there. So this is the one of the curest, one of the commonest and highly curable disease. So I just focus on this, just the benefit of my co-worker, maybe student, maybe not the senior persons. So this is almost 25 to 30% globally. In BP cancer, 35%, more than 35 the leukemias, and so many different cases, and cure rate adaptive therapy more than 95% fiber survival in the Western. So this we can achieve by combining effort, not only inside the country, beyond the border we can take help. Even WHO and CNG is helping to bring all this cure rate of the pediatric in the country. Diagnosis wise, so many things we can do it. Basically cytogenetic and molecular testing, and Dr. P.K. Das already mentioned so many things. So these are the things which is not available in the country. We are outsourcing, maybe in near future we can have. So on that case we can interlink with the neighboring country beyond the border of the country for these things. And we are regularly doing minimal residual disease with the help of the neighboring country and lab. So now not only, initially when I started my career, I have treated leukemia with only the peripheral smears is ALL, L1, L2, L3. Luckily, it was EL3 and first patient is not survived, and EL2, EL3 patients died with only the morphology I have started in 2006 or 7, my treatment. So now every case I have done MRD in our settings, and lots of things in individual in our country as well. So lumbar puncture, these are the things. So in this case, maybe until the country have enough resources on these things, maybe we have to rely on the neighboring country without any hesitations. Because what exactly? Because we are taking the expertise and helping the patient over here. And these are the things in risk identity. Common is just like the inductions, maybe more than 90% and remissions. These are the drugs and consolidation. These are the standard treatment protocol we are following in our country. And this is one of the area advancement. More than 80% patient is cured in developed setting if there is no other certain. But there are still minimal residual disease guided therapy. Maybe we can individualize the therapy. Some blinatumabs and other CAR T cells, these are still lacking in our country, but there is already there some of the patients who can afford it. We can prescribe, they can bring in, they are having. But other things, some of the cases we do have rely on maybe neighboring countries for all those things for the curative and patient interest. And minimal residual disease we are doing regularly, and we can optimize our treatments. If there is no remission, maybe always we have something to do it. Maybe we have to intensify, augmenting consolidation, and we can have the immunotherapy and CAR T cell and stem cell transplant on that way. That's how maybe our cure rate, maybe in BPKMs is more than 60-70% with chemotherapy. If we can add all those things, if patient affordable, maybe our cure rate go beyond the 80%. And this currently the same thing I just have, and this is a blinatumab in the persistent MRD positive patients, and similarly CAR T cell, and there is some primitive start in the Nepal also, CAR T cell and other things. Maybe in due course of time we do have this in country house, but still now we are relying on the neighboring countries on the CAR T cells and advanced immunological therapy. And there are so many clinicals is advancing, and we can reach all those drugs beyond the borders and take care, and we can help the patients, and we can achieve the cure rate as a developed country in near future. Similarly, this acute myeloid leukemia, the next common is around 20% pediatric, which is initially maybe when I started is very difficult to cure, and only stem cell transplant cure when initially in 2000 or the 10 century. But more than 80% patients are cured with only the chemotherapy in this setting, if there is adequate supportive care and permissive care, and 5-year survival. And these are the histologically initially still important. It's important we are relying on the FAB classifications because our lack of advancement of a diagnostic and genetic test in Nepal, but still we are also having some of the other things, just like these are patients who have maybe more frequently have genetic disease, but WHO have a recent classification mostly rely on the genetic evidence. So for that, we have to rely on the neighboring countries or the resources neighboring. And then even we are doing this regularly, karyotyping, cytogenic, we are doing regularly, including MRD in BPKMs and here. But like this, we can individualize the treatment so that acute myeloid leukemia, though it was very incurable disease initially few decades before, now curable with the more than 80% with the chemotherapy. Maybe if we have individualized therapy, maybe we can go with the treatment more than that. There are AML with the myeloid and treatment related and myeloid sarcoma, and there is so many other variety of the AML we can cure in Nepal in our setting as well. So we can classify this disease initially only cell morphology, now the genetic wise, favorable risk, intermediate high risk, so that we can individualize the personalized treatment of the patients, even our setting. Standard treatment, maybe this induction therapy, triple regimen includes cytarabine, downstream etoposide, is still standard care globally, and there are so many new drugs came up, just gemcitabine, and similarly the high dose cytarabine, mitoxantrone. These are in CNS therapy. It can be done in Nepal, so that our cure rate is quite high. So this persistent, the genomic NGS is one of the comprehensive diagnostic tool for acute myeloid leukemia, where we can have individualized with the genetically, and FLT inhibition is sorafenib and gemcitabine, ozamycin, and the anti-CD33 antibody, and so many other drugs is came up with this eradication of leukemic cell in the body so that they can cure and they can have other things. And so many newer Venetoclax is one of the magic drug in acute myeloid leukemia in the relapse. We are using it and same drugs in around. So CAR T cells is very primitive in Nepal. Just started, maybe we are relying on those things. So many advances have occurred. And last not the least, improvement supportive care, just a better antifungal prophylaxis, improve intensive care support, enhance transmission practice, modern infection prevention strategy, multi-opic precision medicine, and so many things you can combine with the expertise and human research so that we can cure the leukemias in our country as in the developed country in the future. So I do not have much time. This is the last slide of my. Thank you very much for a patient hearing, and all the dignitaries, especially please give the hands to both of the minister from India, Dr. Raghuram and P.K. Das, all those things. With that, I just finish my talk over here and hand over to the our chairs. Thank you.
Or we can proceed it in dinner time because we are in short of time. I think we can proceed for the dinner. Then we can have active interaction.
During this, for handing over this dice to me, ladies and gentlemen, distinguished guests and respected doctors, moving forward with our program as we now arrive at very special segment, the felicitation ceremony, we honor our esteemed speakers and esteemed speakers to kindly return back to their original places, please. Please be seated in the front so that we can have you all for photographs and stuff. We truly honor the presence of each and every audiences that you are gathered today. First, we'd like to extend our warm gratitude and felicitate our distinguished speakers. May I now request Dr. R.P. Baral sir and Dr. Jaya Shrestha sir to please come up on the stage to felicitate our speaker, Dr. P.K. Das sir. Sir, please have the honor. P.K. Das sir to please present the felicitation of token of love for Dr. R.P. Baral sir, please. Conference walls to our wards, to our clinics and to our operating theaters, and most importantly to our patients. Thank you all for your gracious presence and your curiosity and your commitment to the lifelong learning and for the lifelong learning and the lifelong learning of becoming a doctor as well. So, on the behalf of the organizing committee, I wish you all a pleasant evening. And gala dinner is being served at the 6th floor near the swimming pool area. Before I close the session officially, I'd like to hand over this mic to Dr. Anil, who is going to give us the vote of thanks and the closing remarks as well. So please welcome him with a huge round of applause.
B.L. Kapoor, speakers, all my seniors, colleagues, ladies and gentlemen. I think I should quote myself again. When people are hungry, they are angry. So I don't want to stay long between the food and you. I'd like to thank Max Healthcare Group for having this CMA here and the international speakers for enlightening us and Dr. Krishna Sagar for enlightening us and the chairs for chairing the session and for all of you for being here and making this program a successful event in this evening. And we hope to have such more sessions in future. Not only talks, but more CMEs, interactive panels. And I think it's high time we all go for dinner. Thank you very much once again. And good night.
We proceed to dinner. I would like to invite Dr. L.V. Sedai sir and all our eminent speakers to felicitate Dr. Nali Hada for her appreciations in hosting the evening. All the speakers and Dr. L.V. Sedai sir, please on the dais.